features growth, especially for the nose, the chin, and extremities of the face, typically you need to have enough IGF-1. And also IGF-1 is a greater anti-diabetic hormone. Growth hormone in the beginning will aggravate diabetes slightly, or a lot, depending on the dose, the first 6 months. But after a certain time, after growth hormone, there will be less fat, more muscle tissue, there will be an improvement in the sugar levels and in the insulin levels. But IGF-1 directly works. You can almost use it as a substitute to insulin if you give high enough doses. So as you see here, the glycemia is decreased, the insulin is decreased, glycosylated hemoglobin is decreased almost directly. So when you give IGF-1 as a treatment, you should not give it fasting and alone, because it can give hypoglycemia. You need it either to give it together with growth hormone in the evening before bedtime or before a meal. So here you see the metabolic profile of the treatment, the plasma insulin level, glucose, C-peptide, and the fatty acids, the free fatty acids. And before IGF-1 and after IGF-1 is the more black line under. But you see that the glucose is decreased from 220, let's say in diabetic patients, 240 milligrams per deciliter. Plasma insulin also decreased with IGF-1. The C-peptide also, and the plasma free fatty acids is about the same. That doesn't really change. What about cardiovascular disease? Let's look now some of those major diseases from which we die, because you will see that studies show with IGF-1 in blood, there's many studies that show a decrease in mortality. Almost about 10 studies. You can find all these references in the new edition of my hormone handbook has just come out, that you can find in the exhibit hall at the UCP booth. You see here, IGF-1 protects against heart failure. If you have levels below the 140 micrograms per liter, which is an average level of a person of 55, let's say 60 years, well, then you have an increased risk of heart disease and heart failure. But above, you have 50% less risk in elderly men. And there are a lot of studies that show cardiovascular protective effect of IGF-1, but we have just an hour lecture, so I'm not going to go into all the details. Here you see also another study that shows you that men and women that are in the highest level of IGF-1 and have a BMI between the 24 and 26 can really have, let's say, better effects on their BMI. Actually, the higher the IGF-1 is, the lower normally the BMI is. But there is a problem in obesity. In obesity, there's a certain vascular IGF-1 resistance, like an insulin resistance. And we'll see that also in breast cancer patients, they have a quite severe IGF-1 resistance. Another study showing you an insulin and IGF-1 resistance in obese rats. And here's a study shows you that IGF-1 is inversely associated with the fat you have in the abdomen in overweight and obese women, meaning that the higher the levels are, the less fat there is in the abdomen. And it's this visceral fat tissue that is linked with more disease like hypertension, cancer, cardiovascular disease. So you better have a high IGF-1. And there are quite a lot of studies that show you that you don't have to be in the upper half of the reference range to be free of additional risk factors. You have to be in the upper fifth, upper fourth of the reference range. So the higher it is, the better it is. And now let's look on the effects of treatment on obesity. This is a study that shows you the synergy. The first column shows you the effect of growth hormone alone on fat mass, 6 kilos less. If you give growth hormone with IGF-1, you have about almost 50% more fat reduction. So it's synergetic. But if you give, you would give IGF-1 alone, it doesn't seem to work so well. So you need to combine IGF-1, in fat people at least, with growth hormone. Now, if you would give IGF-1 to a person who has diabetes, you'll have to lower the insulin injections, the dose of the insulin injections. This is what it says. If you don't, they will accumulate fat. So IGF-1 with growth hormone will reduce fat. IGF-1 with a lot of insulin will increase fat. So here's about weight loss. This is a study that shows you when women lose weight, about half of those women will have higher IGF-1. So you can improve the levels by weight reduction. So let's look here at the bone density. This is in post-pubescent obese adolescents, and you see that actually there is no, this is more insulin. I'm sorry about that. What about health in general? People who have, say their health is not good, usually have low free IGF-1 levels. And what was the greatest effect on me of IGF-1? Actually, my quality of life. I started feeling, let's say, a little burned out. And even with growth hormone, a good treatment, a good diet, I felt tired. I also slept more, which is abnormal for me, who usually sleeps 4 to 6 hours. And even by sleeping more, it didn't improve. Well, IGF-1 corrected that situation. Again, I can not sleep a lot, still feel good, and do a lot of activities, and feel good. Now, may IGF-1 prolong your life? Can you live longer with IGF-1? I already give you some clues that it probably may be so. We know that there are studies that show that people who are growth hormone deficient since birth, there's a special growth hormone deficiency, well, there's a special genetic condition where you have a low growth hormone in certain families, and then others of the family have no problem, have not this isolated gene defect for growth hormone production. Well, the change in life expectancy is huge. This is the greatest among all the hormones. If you don't have your whole life no growth hormone, compared to a brother or a sister who might have enough, you live between 19 and 34 years less. And behind that is probably not enough IGF-1. So let's look here. You see here that IGF-1 reduces the mortality in elderly men and women. Per 100 nanograms per milliliter increase in serum IGF-1, and the average level is maybe 150, but in young people it's 350, men at least, you have per 100 nanogram per milliliter increase a 30% decrease in mortality. And a 60% decrease in mortality when you're 200 nanograms per milliliter higher than the average level. So if you have a big man with a lot of muscles and he takes even a treatment to correct this IGF-1 deficiency that he gets with age, he'll probably be in the upper range. He'll have a 60% less mortality, which means that is about 8 to 10 years of life longer. What are the effects of diet on IGF-1? 3 weeks of a very low calorie diet give a lower IGF-1 to a higher IGF-BP3 ratio, which means there's less bioavailable IGF-1. There's less IGF-1 going into the target cells. So you create a sort of resistance to IGF-1. And high protein diets does not increase more the IGF-1 in piglets, but provides them with less adiposity. So it seems that IGF-1 seems to be more efficient in a high-protein diet. Efficacy is increased. So you should eat more calories, more protein. And what about plums? Dried plums is a functional food for the bone. It seems to improve bone density, and it also increases 70% IGF-1. Don't really know the mechanism about it, so don't ask me. But just to show you that our food is very important. What you eat is important. Normally, you should consider that it's mainly by eating fresh fruits that is better, because dried fruits can give more yeast infection. But this is much better than with sugar. If you would take sugar, that will probably decrease IGF-1. What about weight loss? We saw already the study that showed you that women with massive obesity, when they were on a diet and they lost weight, they had higher IGF-1 and 24-hour growth hormone levels. You see the serum IGF-1 is the columns on the left, and on the right the columns, the serum growth hormone levels. And you see that the lower columns are before treatment, and then after losing 30 kilos, you had normalized the levels of IGF-1 and of growth hormone compared to healthy women who didn't have any weight problems. So obesity is a major factor that causes low IGF-1. This is why when you give growth hormone, for example, to people who are obese, it doesn't seem to work, because there's a resistance. It's because they are low in IGF-1. They cannot make much IGF-1. And they need actually to overcome that to have a combination of growth hormone and IGF-1. Also, strength training in elderly women was in this study was shown to increase the IGF-1. So if you do a sort of resistance, etc., you will increase the IGF-1. So there's many other methods, and this is why we should have a healthy lifestyle with enough exercise to have good IGF-1. I remember also concerning the weight loss, for example, that when I go on a fasting diet, sometimes for 2 or 3 days, I only eat 1 meal a day, and if I check in that period my IGF-1, it's higher. It's about 50% higher than normal. Maybe because of the weight loss that I experienced then. Stop snoring. So people who are snoring usually have a low IGF-1. That's why when you look at people who snore a lot, when you look at their body, it doesn't look like a tonic body. Like the man I showed you, it looks like. So everything's a little loosey. So you know why it's loosey? It's because they have a low IGF-1. There's also some studies, not much, that show you when you give growth hormone treatment, you may decrease the snoring. But it's probably because it activates the thyroid function. Now, so IGF-1 is on certain levels more potent than growth hormone, and I cannot imagine anymore an optimal treatment that would reverse aging. Let's forget the notion of anti-aging treatment reversing without IGF-1, because it's with IGF-1 that I had the most spectacular improvements, but I had them in maybe 1 patient on 3. With growth hormone, it always works in almost everybody. But when IGF-1 works, it's often very spectacular. You really do have a person who can look more than 10 years younger. So this is the second edition of my hormone handbook, where you have the whole treatment explained with 18 other hormones. There's 6 more hormones more than the last time. I personally prefer this book. It's much better. The other one was already quite good, I think, seeing its cells. But this is my preferred. Because at least I talk about treatments you may not know, and that are very important. We'll talk tomorrow about oxytocin and vasopressin, but you see that these hormones are necessary in many people. But IGF-1 is the most potent of all. And this is the IGF-1 on the market. It's called Increlex from Ipsen. firm. It seems you may have some problems here in the States to have it. I had patients who had them in the pharmacy in New York at a 30% cheaper price than we have it in Belgium. So you might have to, it maybe depends on which state you are in. And it's called mecasirmin. But mecasirmin is the bioidentical IGF-1. Just a new name because probably they have a sort of patent on it. It's extremely difficult to have because they want to keep the supply for children who cannot grow without IGF-1. And I don't know why, they seem to have some production problems that they cannot increase their production. It costs between $700, that was in the New York pharmacy, and 950 euros, that's in Belgium, 950 euros, something like $1,300 or $1,200. There's another preparation where it's sold, it is IGF-1 with IGF-PP3. So there are a lot of clinical trials that have been there a lot. It's not fantastically a lot, but you can find all those references also in my hormone handbook. And Iplex is the one that is sold with IGF-PP3. IGF-PP3 is the major binding plasma protein of IGF-1. It's the one that transports IGF-1 from the liver, it's mainly made in the liver, to the target tissues. And it's on the market because it seems to be a better way to improve patients with amyotrophic lateral sclerosis. But there are mixed findings about that. Some studies say it helps, some studies say it does not help. I have a patient with amyotrophic sclerosis lateralis. We even did mesotherapy with the IGF-1 on his back. And he didn't seem to improve, but it's only after 2 months of treatment, 2 months and a half, his walking. He still is tired when he walks too long. But what did improve is his functional capacity or ventilation capacity from something like 60% to 75%. So at the university, they're very happy about that. They say this is something very difficult to obtain in a patient with ALS. So this is Iplex, this is the IGF-PP3. You see it's a much longer molecule actually than the recombinant IGF-1. It's the same firm who puts it on the market. And so this is Iplex, IGF-1 is 70 amino acids, while it's 264 amino acids in IGF-PP3. In general, in blood, you need to have, in micrograms per liter, 10 times more IGF-PP3 than IGF-1. So if your level is, for instance, of 300 IGF-1, you need to have, to be healthy, an IGF-PP3 around the 3,000. If the IGF-PP3 is 6,000, it's 50% neutralization of IGF-1. It's like having 150 micrograms per liter of IGF-1. If there's too much plasma binding protein, the IGF-1 stays in the blood and does not go in the cells. So this is also what you can find through internet. Now, through internet, in my experience, because I've tried some of those for growth hormone, for example, it's not that the product itself is bad or badly prepared, it's that they forget to put preservatives in it. In order for it to hold, you need to have preservatives. And the preservative usually used is 0.9% benzyl alcohol or ethanol. And they usually don't have it, so when you open up and you start using it, after 2 days, it doesn't work anymore. We had this with the gintropin that was on the market. Even the official firm in China asked me to try it. And I'm extremely sensitive for growth hormone. If I take the usual dose that I give to my patients, I would get acromegaly almost I'll get a lot of muscles anyway. So any change I can feel, and I had to inject 8 times a higher dose of gintropin to have an efficacy. But they didn't put a preservative in it. That's the reason. Because I have to take small doses, so I use it for a long time, and then I pass the 2 or 3 days that it can hold. So there's a whole series of pharmacokinetics There are actually, IGF-1 in blood is bound to 6 IGF-1 binding proteins. And following the studies here, they say in the flyer that they put it, more than 80% is bound with IGF-BP2. I saw also statistics studies showing 67%. But anyway, it's by far the major transporting binding protein, and you need enough of it also to transport. If the levels are too low, when the IGF-1 goes in the blood in the organ, in the beginning everything would go inside of the first part of the organ, but not in the rest, because if there's too low binding protein. So you need enough binding protein, but not too much. And this is the pharmacokinetics that you have in a number of hours when you inject. You see that when you inject, very quickly it goes, but it even remains longer for hours after the first day. So it's something that can remain quite long in blood. See, depending on the dose, of course, if you give a higher dose, you'll have higher levels. And for the pharmacokinetics, if you would provide Iplex, you will see that IGF-BP3 even is more stable than IGF-1. IGF-1, after a number of about 30, 40 hours, is already back to its initial situation. It does take actually 60 hours to completely be back to the normal situation. These are studies in children with severe primary IGF-1 deficiency. They have enough growth hormone, but they have receptor deficiencies. They cannot make IGF-1. So what is the treatment doses that you usually should give? First, the vial is 40 milligrams. It's 40 milligram vial. And that's enough for most patients. Patients who are not totally deficient in IGF-1, it's enough actually for 3 months treatment. But on the box of the vial states that it only holds 1 month. That's not true. If you're very careful, you put it in the fridge, it holds on longer. And what they advise is to administer it before a meal or a snack because of its hypoglycemic effects. But in my experience, when you administer it together with growth hormone, you neutralize this possible hypoglycemia. And as the doses I'm proposing you to give are small, you don't usually have the hypoglycemia you have in children who get huge doses. Because one of those, the problems of those children that are called children with Laron syndrome. Laron syndrome is the Israeli researcher who found out about this deficiency in them, is that they actually have probably more deficiencies than just IGF-1. And in research, they often just give then one hormone. Then it's less potent. They have to give much higher doses to overcome a certain resistance to the hormone. So they advise if you are not able to eat, then not to inject. But there's no problem if you would give it together with growth hormone at the same time. So how to use it, that are just strategies on how to put it here. That's, of course, you have to do it sterile. You have to take your... It's very important to do it as sterile as possible because you will try, because of the cost price, to use it for a longer time with your patients or on yourself. And so what I do is I take out of a syringe. It's a mixed solution. You don't have to mix it. So it's already mixed beforehand. I take with a subcutaneous syringe, I take enough for 3 times injection. And then so I put my syringe that is full with the quantity I need for 3 days. I put it in the fridge after I've used it, then I use it again 24 hours after. And that seems to have a good effect. And in this way, you don't penetrate in the vial too often, because that could bring contamination. So how you use it, you can put it on the same place you can put growth hormone. Basically, it's on the belly and the thighs mostly, but you can put it on other places. I tend to put it here on the sidewards of the buttock because there are places there where there's not much sensitivity. No real, probably not a good innervation. In many people, you have some places there. So how to use it? Adverse effects you can have. You can also have allergy has been reported. I never had that in my patients. You can have some neurological toxicity in neonates. What IGF-1 does is a bit the same as growth hormone. It decreases cortisol levels. There's studies about that. And when you decrease cortisol, you have then cortisol deficiency signs, like low blood pressure, feeling low stress resistance, you inflame all over. And they say it's contraindicated neoplasia, but there's not really been a study done on that. It's just, you need to keep your license, you need to be a little careful as long as you don't have a study there. It seems that it can, if you give too much, give a tonsillar hypertrophy in children. But that's, of course, because they use high doses, so you won't have this problem with your patients. You're going to give physiological dose, not pharmacological dose, no doping. Also, it seems to create, like growth hormone can create, intracranial hypertension in 3 subjects on a big number of subjects. And when you stop the treatment, it goes away. So it's sort of a headache that it gives at that moment. So, but basically, this is only what in high doses that you have these problems. So here, recombinant IGF-1 at 2 to 2.8 milligrams in morning dose gave no hypoglycemia young and middle-aged adults. And what is the dose that I'm proposing you to give? Is something like between 0.1 and 0.5 milligrams. So you're far from that. And that's enough often. I even have patients who have to take it every other day because otherwise they swell all over, because it also has, as growth hormone, water-retaining effect. So among the other problem, hyperglycemia is almost spot, which is a little paradoxical, but this is with Iplex, maybe because there's too much IGF-BP3 that withholds the IGF-1. Pain and extremity headaches, but it's actually not something very often. You see here all other information you can find on the brochure. Acromegalic changes, you need to give very high doses, so this you may not have. Now, it seems that injecting IGF-1 and IGF-BP3 is not such a good idea in normal people, you would say, or people with a normal IGF-1 deficiency, not in those cases of amyotrophic lateral sclerosis, because there's much more antibodies than formed after a period of 9 months against this antibody complex. But also one of the reasons that they make more antibodies in these studies is that they are lowering the cortisol. Then you have your immune system who goes out of control. You may never lower cortisol if you cannot, except if it weighs too much. Cortisol is also a very healthy hormone on the right doses, not in overdose. So what is the effect of IGF-1 on other hormones? It seems actually to have a transient effect of increasing adrenal hormones, but then it seems to decrease them, like it decreases almost systematically cortisol. And what is the effect of other hormones on IGF-1? Well, the thyroxine, for instance, will increase IGF-1 in heart and liver tissue because it increases growth hormone production, increases also IGF-1 production. So thyroid hormones may increase at least in normal doses, not in overdose. Insulin can also increase IGF-1, IGF-BP3. Among the hormones that can increase IGF-1 actually is, of course, growth hormone. That's maybe 2/3 of the level of IGF-1. Protein intake is very important. You will not increase very much IGF-1 without enough protein intake. So that's something like half a pound of meat or fish a day. And insulin, thyroxine, and also androgens. You can increase IGF-1 levels by giving male hormones. So that's why we always have to combine these treatments. You see here that transdermal estradiol also increases IGF-1 against oral. Actually, what oral does, when you look at the levels here, the levels are at the left oral are lower. If you put a person to transdermal, there's an increase. In general, when a woman takes a birth control pill, that's an oral estrogen, her IGF-1 decreases by 30% on the average. That's why you don't have a 100% beautiful woman on a birth control pill, because the body loses its firmness. So if you want to choose a beautiful partner as men, you have to choose a woman without birth control pill and have a lot of babies. But she'll look better. So are there some nutrients that can increase the IGF-1 levels? High serum zinc levels, the more zinc you have, the more higher IGF-1 level can be, in lambs at least. It's also good to have enough iodine, because otherwise your IGF-1 levels are lower. Iodine, another study shows that iodine increases IGF-1 and IGF-BP3. So you need something like 0.5 milligram of iodine. Not much more, actually. So what is the effect of drugs on the serum IGF-1? Well, if you would give an ACE inhibitor to your patient, you will see that the patient will progressively become older because the IGF-1 decreases. And then you're not more an anti-aging doctor or reversing aging doctor or a normal doctor, you're just a premature aging doctor. And if you put that on your office, you'll be the only one. Isn't that an honor? So basically, this is to give you a good view of, I think it's an extremely important treatment. We have to put much more pressure on the firm that makes it in order to obtain it. And I didn't show you a beautiful slide, but there's really an interesting slide that breast cancer, most statistics on breast cancer show that people with high IGF-1 have more breast cancer. And then you would say, it's dangerous. But there are two studies actually. One study shows you that in breast cancer tumors, there's on the average between 30 and 70% lower amounts of receptors. So they are IGF-1 resistant. They are actually low in IGF-1 in a certain sense. And another study shows you that the lower the IGF-1 is, the more severe you have cancer. If you have breast cancer, the more nodes you have, or risk of nodes you have, the more metastasis you have, the more extension, more invasive it is. So, another cancer, for instance, cervix cancer, is related to low IGF-1 levels. If you're in the lower quartile, lower 25% of the lab test, you have 4 to 5 times more risk, and there are two studies show that, 4 to 5 times more risk of cervix cancer. So and there are some studies show you in prostate cancer patients, not all, that show you that the higher the IGF-1 level are, the less risk there is of prostate cancer. On the other hand, there are other studies that seem to show you an increase in risk. So there's a sort of mixed feelings. But also there, studies in animals, in rats, have shown that tumors can make IGF-1. And that would signify that it's not the IGF-1 that causes the cancer. It is the cancer that causes the IGF-1. It's just a marker, a consequence of cancer, and not the cause. I thank you for your attention. Do I have time for questions, or? Okay. Yes.
Just several questions. Number one is, what level of IGF-1 would you like to achieve generally?
That's a good question. What level of IGF-1 would I try to have in my patients? It will be different from one patient or other. Right. If you have a very tall man with a lot of muscles and big, he needs to have a higher level than the average level of a young person of 25 years of age, which is 350. He needs to have 450, for example, because he always had a lot of IGF-1. If you have a very thin person and a small person, that person never had, as an adult, a lot of IGF-1, and you don't need necessarily to make of him a sort of giant, because it's not possible, or an acromegalic dwarf that is, so you need to have a lower dose, something like 200, 250 micrograms per liter.
I've actually tried to get the IGF-1, and it's really prohibitive. It's actually the one pharmacy really wanted documentation on dwarfism and, just children not growing. And I was trying to use it for...
If you want references, you have them all in my hormone handbook. There's on all the diseases.
No, it's just
and all
from
the
a
things.
pharmacy to get the... Yeah. It's just from a pharmacy to get the
we have the
IGF-1.
same problem in Belgium, so I get them from Germany.
Oh, I see. Okay.
So go in another country. Go take them on Canada.
I'll fly to Germany. But the second quick question, what dose do you use, 0.1 to 0.5?
So in my patients, it's 0.1 to 0.5 milligrams on the average, which is, on the syringe, 0.01 milliliter or 0.05 milliliters. And that's usually enough. If you give more, you get overdose, you get swollen.
Okay, thanks.
Yes?
Questions. Question number one, the relationship between patients which are already on testosterone supplements and IGF-1. That's number one. In patients which are treated with human hormone gonadotropin and IGF-1. Have you noticed the relationship between the two?
All anabolic hormones will increase IGF-1, basically. And ACG increases testosterone levels and estradiol levels, so you will have high IGF-1 with it. And that's probably, it's human chorionic gonadotropin, I'm talking it in the seminar I have next week, is a sort of anti-obesity hormone in the sense that decreases appetite, but also people can lose a lot of weight if in a low-calorie diet without losing their muscles. They seem to maintain their tonus. And it's probably, the mechanism behind it is probably that it maintains the IGF-1 levels at a good level. Because when you're on low-calorie diet, very low-calorie diet of 500 kilocalories, it should go lower.
So I guess what I'm trying to ask you in terms of my first question about testosterone, do you shoot for optimized testosterone levels before you put to your patients IGF-1?
I always do that. The IGF-1, because of the cost price also, is a second stage treatment. You first give treatments that are, let's say, less expensive and that work in many people. And then if it doesn't seem to work out sufficiently, then I add IGF-1.
All right, how about the same issue with the people which are already in human hormone gonadotropin?
Human chorionic gonadotropin normally is a treatment you may not continue for longer than 40 days because then you make a sort of reaction antibodies and then you need to stop at least 6 weeks in order to lose this sort of immunity against that also makes it doesn't work anymore. So it's not a treatment you should do on a permanent level. ACG is used as a treatment to change something in your diencephalon or hypothalamus that you have afterwards less appetite. It has other effects than just increasing the sex hormones. And so I would not combine the two together permanently. I wouldn't do that, especially as it comes from often it's from living origin. It's not from synthetically made, the ACG that you usually use. So you have to watch out with it.
Okay, thank you.
Yeah.
Just out of respect for time, be concise.
Do you want me to talk fast? Yes. Okay, fine. Hi, Mark Gordon. Dr.
I hope
Hertoghe,
I'll be
thank you very
able
much.
to understand you if you talk fast.
No, you'll be able to. Concerned about IGF-1 and some benefits of IGF-1. IGF-1 in why the longevity issue is they're finding that the ribosomal 40-60 subunits are upregulated with IGF-1 but not with growth hormone. But in giving IGF-1 and not giving growth hormone stimulates binding protein 3, which a Harvard study has shown that gastrointestinal cancers are reduced by 46% just by increasing IGF binding protein 3 by 26 nanomoles. So in giving just IGF-1, you bypass the hepatic production of the binding proteins, which will therefore increase your risk for cancers. But the combination of growth hormone and IGF-1 works very well.
Yeah, I think that's the best is indeed to do the combination. I don't know about the effects of IGF-1 on the IGF-BP3. I don't know if it lowers or increases. I thought it increased. Yeah, so it's the growth hormone directly that increases it.
When you are
But it also works with growth hormone for most of the effects. I always join it with growth hormone because it seems to be better. There's only one patient that is only on IGF-1 because he doesn't feel any effect with growth hormone and a lot with IGF-1. Yes?
When you're checking serum levels, are you going to be checking a free IGF-1 or a total IGF-1? Is there a difference?
I always like to ask serum IGF-1 and IGF-BP3, and never do one alone, because you can have a very good IGF-1 and still be IGF-1 deficient because you have a very high IGF-BP3 and there's not much IGF-1 going into the cells.
Okay,
Person
so
who are dehydrated, for example.
What are your levels for IGF-BP3 then?
The what?
What are the levels are you looking for the IGF?
If you would express it in micrograms per milliliter, it's 10 times more. If you have, for instance, like I told, 300 micrograms of IGF-1, you need something like 3,000. You need a little bit less IGF-1 in women and a little bit more in men. Okay?
With regards to the HCG increasing, do you think it's a combination of the very low-calorie diet and the HCG that increases the IGF-1, or do you think it's the HCG?
The very low-calorie diet normally at the long term is protein. If it is protein deficient, that is, will decrease IGF-1. If it's protein sufficient, it will not decrease the IGF-1 much. And HCG, as it increases testosterone, and may even increase the conversion of T4 to T3, thyroid hormones, it will increase the IGF-1. But indirectly by increasing other hormones.
Hi, thank you, that was great. I was wondering, this goes back to the IGF-BP3. There is some literature that suggests that if there's a discrepancy between IGF-1 and IGF-BP3, that is, one is high and the other is low, or vice versa, that you really need to look beyond what's going on and rule out a malignancy. I've seen that several times just clinically as well. So I'm wondering, along with the other gentleman, the use of IGF-1 alone in isolation without growth hormone. You just said you use it together with growth hormone, so what doses of growth hormone are you using with it?
So the growth of growth hormone normally that are sufficient to maximal activity, and if you give more, you get overdosed, with IGF-1 are often around the 0.2 milligrams. And if you would increase, you might get overdose symptoms with IGF-1, because IGF-1 really activates a lot of hormones. It seems to activate the effects of growth hormone, seems to activate the effects of thyroid hormones, and so you do have to decrease other hormones when you give IGF-1 often.
I see. I guess the part of it that is a bit confusing or contradictory is that growth hormone, IGF-1 is a metabolite of growth hormone. So
it's not a metabolite, it's a complete different hormone made but it's a hormone made under the influence of growth hormone in the liver, but it's a complete different sort of peptide or protein.
It is, but giving growth hormone for people who don't have a resistance or a low, most patients respond with an elevation in IGF-1, at least in my experience.
And IGF-BP3 together, yes?
Yes, exactly.
But more IGF-1 than IGF-BP3, so you get more by
Usually it's actually comparable, so I look for that rise in both of them because it worries me when I don't see that comparable balance between the two.
Yeah, so you do have to watch out. You need to check the levels, and if you have a decrease in IGF-BP3 and increase IGF-1, that's not good. So you should have good levels of both and not too low IGF-BP3 because it's cancer protective in most of the study, not in all.
So I guess my question really is, what percentage of patients are actually resistant to the rise in IGF-1 on growth hormone alone that would drive you to using IGF-1?
Well, I just said in the beginning, I think every person above 50 years is a candidate to IGF-1 treatment, even though that person is taking a high dose of growth hormone. If you need a high dose in a patient of growth hormone, you're doing that because there's an IGF-1 resistance or not enough IGF-1 production. Mm-hmm. And we should never give high doses of hormone. If we need to give high dose of hormone, that means that there's actually another hormone being deficient.
Well, let me just point out two cases quickly. But I have an 84-year-old gentleman, he happens to be the oldest gentleman in my practice, who started with a free testosterone of 14 and an IGF-1 of 120. After 1 year of increasing his testosterone to more like 120, his 3T, his IGF-1 went up to 240 spontaneously. Secondly, there are many patients that I have where I use minimal doses of growth hormone, such as less than 0.2, 0.15, 0.175, and they have a very dramatic response with IGF-1s that go up to 250, 300, 350. So,
but don't forget that you're testing with the chemiluminescence test of IGF-1, which is not accurate. You need to check with radioimmunoassay. But anyway, what you say is totally true. When you give testosterone or you give growth hormone, you increase your IGF-1 in many patients, etc. But you'll see that the same patients that responded well before age 50 start then to respond less and less well. And you need to add IGF-1 then. Okay,
Thank you.
Thank you. If there are any more questions, I'll be at the booth of the UCP. Thank you.
Terry, that's great.